Okay, well, welcome everyone. We've got people from Port Moresby and from Alatau, and let's see where else. A couple from Alatau, Honiara today, and a few other places. So today I wanted to talk about epilepsy in children, and not so much about the acute management of seizures, because I think we have talked about that before, but I wanted to talk a bit about the chronic management of children with epilepsy, because it's very common. We all have children. Every provincial and district hospital has a number of children who have epilepsy, and they can, if they get good management, they can have a very good outcome, generally speaking. When there's a gap between their needs and the treatment that can be offered, then sometimes children with epilepsy have a very good outcome. And I think we perhaps get used to the not so good outcomes from children with epilepsy, and it's good to know about the basics of the management of epilepsy and how we can look after such children. So here we go. This is what I wanted to talk about. I'll say something about the definition, because it's important that we know what the standard definition of epilepsy is, and that's been well worked out over a long period of time. So we'll talk about that. We'll say something about how common epilepsy is especially in low and middle income countries. It's more common in such countries than it is in higher income countries, and sometimes there's a bit of a difference in the origins of epilepsy in certain countries. We'll say something about the terminology of epilepsy. I think this is quite confusing, and the classification. I just want to talk about a very basic classification of epilepsy. There's very complicated classifications, but we'll try to talk about a basic classification of epilepsy. And we'll say something about the different types of seizures that can occur. So, because that relates to the classifications to some extent. I guess it's important to recognize that when children with epilepsy have some comorbidities, whether it's other neurological problems or developmental problems or intellectual problems or any other problem, a cardiac problem or a respiratory problem, then their outcome is their management is much more complex, and we have to put more thought into the management of such children who have not only epilepsy but something else as well, and that accounts for many children that we manage. We'll say something about the causes of epilepsy in terms of the classification, and something about these things called epilepsy syndromes, only in as much as they can influence the choice of medications you use and the prognosis and the way you can discuss epilepsy with families. I'll say quite a bit about anti-epileptic drugs, and I'll cover the anti-epileptic medications that are most commonly available and most commonly used. And we'll say something about the side effects of those drugs, and then wider management issues. So the definition of epilepsy has been drawn up by the International League Against Epilepsy, and has been adopted by the World Health Organization. And the definition is to a person, a child or an adult who has at least 2 unprovoked seizures occurring more than 24 hours apart, that is separated by at least 24 hours. And so the key things are 2 seizures and unprovoked seizures. And by unprovoked, I mean not associated with fever. So a febrile convulsion is not an unprovoked seizure. If a child's got meningitis or some other acute injury like cerebral malaria or trauma, then that's not an unprovoked seizure. They're provoked seizures, if you like, under that terminology. Of course, those children who have cerebral malaria or brain injury or meningitis can develop epilepsy, but that's if they have a seizure during that. I'll just have to admit some people. If they have a seizure during their acute illness, let me just see how to admit people. No, lost it. If children have a seizure during their acute infection or illness, then that's not epilepsy in itself. Now, the other thing I find it quite useful when you're looking at children who have a movement disorder of some sort that you're not sure whether they've got epilepsy, then to actually look at the what's actually moving. So most seizures are convulsive in nature, not all of them, but most of them are. And what you typically see is the same muscle groups moving repetitively. And the seizures are not suppressible by just gentle pressure on the limb. So if you touch the limb and try to just hold it gently down, then the seizure will occur through that. If you can calm the limb movement by gentle touching and gentle pressure, then it's probably not a seizure. It's probably some other form of movement disorder. So there are some things that are called seizures or epilepsy, and they're not. They're just a movement disorder. And then sometimes we underdiagnose epilepsy. We don't recognize that it's there. So it's just important to have the definition in mind. So 2 unprovoked seizures occurring more than 24 hours apart. I want to go back to talk a bit about febrile convulsions, because they're the most common type of seizures, aren't they? Febrile convulsions are the most common type of seizures, but febrile convulsions in themselves are not epilepsy. And febrile convulsions occur in 3 to 7% of all children. So it's probably about 1 in 20 of all children will have a febrile convulsion up to the age of 7 years. And about a quarter of those children will have had a family history of febrile convulsions. They tend to run in families, although not always. And they also occur a bit more commonly in children who've got a family history of epilepsy. Now, most febrile convulsions, most children who have a febrile convulsion don't go on to have a further febrile convulsion, but about a third of them do. And a small proportion of those go on to have afebrile seizures and have epilepsy, right? So just important to make the distinction between febrile convulsions, which are provoked seizures, and epilepsy. I won't talk too much about febrile convulsions today. We've got other things to talk about. When we're thinking about epilepsy, it's another good example of how we need to make a distinction between the prevalence of a disease and the incidence of a disease. Now, the prevalence of a disease is the number of cases that exist in a population at any given point in time. And when you hear about how common epilepsy is, sometimes people are referring to the prevalence of the condition, and sometimes they're referring to the incidence of the condition. So the incidence of the condition is the number of new cases that occur over a given period of time. It's usually per year. So the number of new cases of epilepsy occurring over a year, that's different to the number of cases that actually exist in the population at a given point in time. Because epilepsy is a chronic illness, it's good to describe it typically in terms of the prevalence within a population. And so when you're reading about how common epilepsy is, we need to keep that in mind. It's said that epilepsy among people of all ages, so children and adolescents and adults and elderly people, occurs about 10 per 1,000. About 1% of all people especially in low and middle income countries, have epilepsy. That's the prevalence. And it's even higher in some areas, particularly in rural areas. For children, the prevalence estimates can be even higher. And it's said that somewhere between 1 and 4% of all children will have epilepsy. So about in some populations, about 1 in 25 children will have epilepsy. In some other populations, it's not as high as that, but about 1 to 4%. So it's a very common condition, that's why we need to be good at managing it. The incidence is different. That's the number of new cases that occur, say, per year. And the estimated incidence by the World Health Organization is 82 per 100,000 population in low income countries. So that's the number of new cases per year. That's different to the number of children or adults that have epilepsy in the population at a given point in time. I want to talk a bit about the terminology of epilepsy, because I think it's quite confusing. And I think it's probably sensible to just separate the terminology into just 2 areas, especially into focal seizures and generalized seizures. And the reason it's important is that different medications will work better in focal seizures and different medications will work better in generalized seizures. So there are some medications that won't work well in generalized seizures, and there are some medications that cross over between focal and generalized seizures. But it's true to say that some focal seizures that start focally become generalized, and some children have a mixture of both. They have both focal and generalized seizures. And so in some ways it doesn't matter too much, but in terms of deciding what's the first medication you would use, it's good to be able to distinguish between focal and generalized seizures. If a child's got focal seizures, then they have just focal symptoms and signs. They may have a focal motor manifestation, and that sort of epilepsy originates within the neural networks within one hemisphere. And sometimes they spread to the other hemisphere and become generalized, and sometimes they don't. Sometimes they remain focal. Generalized seizures are different. They rapidly engage or involve neural networks in both cerebral hemispheres. And so that's why the child has generalized tonic-clonic epilepsy, for example, whereas a child with focal seizures may have some sort of aura or manifestation, like they might have an auditory aura or some other sensation, a sensation of nausea or headache or something they have before the seizure, and then they have a focal seizure. That's typical of temporal lobe seizures that originate from the temporal lobe. So that they're a classic focal seizure that arises from the temporal lobe, whereas generalized seizures arise from both cerebral hemispheres. I'll just admit a few people now. So when we're thinking about terminology in epilepsy, there's lots of different terms, but just think about, is it focal, is it generalized, and is it focal becoming generalized, or does it stay focal, for example? This is the international classification of epilepsy, and as I say, think about things as being seizures as being focal or generalized or uncertain. And this is, I think, quite a simple and useful classification where you're describing whether it's focal in onset and whether the patient is aware or has impaired awareness. Then is there a motor component, and does it become bilateral? Does it become generalized? So that describes focal seizures, I think, very well. For generalized seizures, they're either tonic-clonic or there are other motor seizures, such as myoclonic seizures or something else. And sometimes they're generalized without motor convulsions, like without convulsive movements. And that can occur when there's in absent seizures. And absent seizures are a form of generalized seizure. Okay, it'll become more obvious as we go on. And then there's unknown onset, but unknown onset seizures are essentially the same in that they can be focal or they can be generalized. They can be tonic-clonic or they can be myoclonic, etc. So the main thing is to try to identify whether it's focal or generalized in origin. The causes of epilepsy are interesting, I think, and most causes of epilepsy are what we call idiopathic. But now we're finding lots of different causes. So most of the causes of idiopathic or unknown, idiopathic just means unknown, most of them have some sort of genetic origin. They're often polygenetic. That means there might be several genes that are involved, or sometimes they're monogenetic, and sometimes they're completely unknown. And I guess the most important thing is to exclude the treatable causes of epilepsy. And then in most cases, we actually won't know the cause. It doesn't matter, we won't know the cause. But then there are causes of epilepsy that are caused by other brain diseases. So if you think about it, any sort of brain injury can result in epilepsy, whether it's an infection or some sort of stroke, an ischemic event to the brain, whether it's trauma or a brain tumor, or for some children, it's that they've been born with some sort of malformation of the brain, say cerebral dysplasia of some sort, some abnormal malformation where that increases the risk that a child will have epilepsy. And then some children are born with with inborn errors of metabolism, so that they may have a chemical that sets off their epilepsy. And then rarely, but I include it because I think we should be looking for this a bit more, and that is to measure the blood pressure of all children who have seizures, because occasionally you'll see a child who has severe hypertension that's caused their seizures. So the main thing is there's lots of different causes of epilepsy, but most of them are idiopathic. Most are idiopathic, but also think about these other causes: infective, ischemic, vascular, trauma, tumor, some sort of inherited or cortical malformation, inborn errors of metabolism, and hypertension. The patterns of epilepsy that I described before are fairly useful, focal or generalized, are somewhat useful in terms of deciding on what the right treatment is and sometimes what the prognosis is, and sometimes they can help us explain to parents what might happen. Then there are some other epilepsy syndromes that can be recognized. I mentioned before temporal lobe epilepsy, and there's a number of different other types of epilepsy syndromes that occur in children. And if you can recognize those patterns of epilepsy, then it can help us understand the prognosis. Some of these have a good prognosis and some of them have a poor prognosis. So I'll just go through a few of these, not to be too focused on these epilepsy syndromes, but if we do recognize them and we recognize the characteristic pattern, then it can help us explain to parents what's going on. The first one I wanted to mention is called benign Rolandic epilepsy of childhood. And it's a form of epilepsy that has a good prognosis, and it occurs in about 15% of all childhood epilepsies. Usually the children are somewhere between 3 and 10 years, so they're not quite at school age, but they can be at school age level, and it's usually gone by the time the child's a teenager. Most of these children they have very few seizures, or they remain seizure-free after their adolescent years. So again, it's a good form of childhood epilepsy in a way, because it doesn't progress to anything more serious usually. And the characteristic is that these children have seizures at night, and it's usually in the early hours of the morning, like around sort of 4 or 5 o'clock. And their parents will often present their child because they've found the child having a seizure in bed just when they were about to wake up. And usually that the children will have a generalized seizure, but that can be preceded by some focality, by some aura, such as some grunting noises or some speech that's slurred. But usually it's a generalized seizure, and they're usually quite brief. The seizures are brief, but they happen at a characteristic time in the morning. And I tend to put such children on some anti-epileptic drugs, but not all people do. Sometimes they won't go on to anti-epileptic medication, and they will still resolve. They'll still get better. I tend to put these children on anti-epileptic medication because I think most parents want something done, and also the very small risk that a seizure that occurs unwitnessed while a child's sleeping at night might result in vomiting or aspiration, or something that's more serious, might lead on to something more serious. But benign Rolandic epilepsy, the children who have benign Rolandic epilepsy are also neurodevelopmentally normal. They don't have any other neurodevelopmental problems or intellectual disability. They're otherwise quite normal kids. The next epilepsy syndrome I mentioned before, which is childhood absence epilepsy. And sometimes we think that must be a focal epilepsy because it's only really involving the sort of conscious state, but it actually is a form of generalized epilepsy. And again, so Rolandic epilepsy causes about 15% of all childhood epilepsy, and absence seizures cause a similar proportion, about 12%. Again, the onset is somewhere usually between 4 and 10 years. And these children have very, very brief periods, usually lasting for only a few seconds, where they will just briefly lose consciousness. They will zone out from what they were doing. And sometimes it occurs in children who are at school, and they might have periods where they can't grasp or they can't learn because they're having multiple absence seizures, and people don't actually notice. And sometimes they will have periods where they have unconsciousness to the point that they may fall, but usually it's a bit less serious than that. Most of these children with absence seizures, they respond very well to medication. Remember, it's a form of generalized epilepsy. So I'll go on and talk in a moment about how we treat generalized epilepsy and how we treat focal epilepsy. And the good thing about absence seizures is that most children grow out of their seizures by usually about the age of 12. Again, adolescents, they tend to grow out of their seizures. And some children who have absence seizures might have other forms of seizures, and that can make their epilepsy a bit more severe. So we've talked about Rolandic epilepsy, we've talked about childhood absence epilepsy as being two relatively benign forms of epilepsy from which most children grow out of. There's another type of epilepsy called juvenile myoclonic epilepsy, and that occurs a bit later, so usually in young teenagers. And these children tend to have myoclonic jerks, so brief muscle jerks, typically of their upper body. They may also have some generalized tonic-clonic seizures, and they may also have absence seizures. This is a bit similar to Rolandic epilepsy, and it usually occurs when the child is waking up from sleep. But again, it's occurring in young teenagers. It usually, again, is usually a more benign form of epilepsy. It becomes less severe in later life, but these teenagers have to look after themselves reasonably well. And if they have anything that triggers a worsening of their epilepsy or their seizures, then often they will have more seizures. So it's just as important that you tell them they must get regular sleep, they must avoid drinking too much alcohol or other things that may trigger their epilepsy. And usually, again, these children grow out of it. So we talked about Rolandic epilepsy, we've talked about absence seizures, and we've talked about myoclonic epilepsy, juvenile myoclonic epilepsy. And lastly, there's a condition which we've all seen, which is called infantile spasms. And this is unlike the three other types of epilepsy I mentioned before. This generally doesn't have a very good prognosis, and generally the children will have severe neurodevelopmental problems. These children start having epilepsy or seizures in the first year of life, and they may have had a previous brain injury. All of those things I mentioned before, meningitis or encephalitis or cerebral trauma or something like that. And that they may have had a previous brain injury in the first 6 months of life, or sometimes infantile spasms or so-called West syndrome. It will arise even without some pre-existing brain injury. And these children have spasms affecting the whole body. It's often sometimes called salam spasms, because it's similar to both the arms and legs are moving in a rapidly flexed posture. And they may have 10 to 100 of these individual spasms per day. I mean, they're very often very disabling, and children with infantile spasms can rarely develop neurologically because they're just having seizures so constantly. Why recognizing this is important is that the standard forms of anti-epileptic drugs don't always work in children who've got infantile spasms. And while we might use phenobarbital or some other medication, they won't always work. And so for these children, they sometimes get treated with steroids, and sometimes that has a benefit. Many of these children have spasms that don't respond well to medication, and many go on to have other learning or behavioral disorders, and some go on to develop this condition called Lennox-Gastaut syndrome, which is really it's like a juvenile form of infantile spasms, where children have typically multiple different epilepsy seizure disorders, seizure types with generalized tonic-clonic seizures and absence seizures, and they invariably have some degree of neurodevelopmental delay. It's not always severe. And so some children who go on to get Lennox-Gastaut syndrome can lead a reasonably functioning life, but typically they have quite significant neurodevelopmental problems. Now, I wanted to talk about choosing a medication for epilepsy, and usually the medication we choose is the one that we have available, and that's okay. But it's useful to think about the best choice of medication in this particular child. And so I think you base it, I try to base it on 4 things. One is the seizure type. Is it focal or is it generalized? Another one is the drug availability and how reliable the family will have access to that particular drug. Right? It's no point using a new drug that seems to be better if the family will only have access to the drug for a month or two, and then they won't any longer have access. So choose a reliably available drug. So the seizure type, is it focal or generalized? A reliable access to the drug. And then the other important thing that we need to consider, especially in older children, is the side effect profile. And in some ways, that's really choosing a drug based on what you want to avoid. And some drugs have side effects for some children that they just don't want to have. And so as they get to be older children and young teenagers, I think it's important that we know what the side effects of the drugs are, and if there's an equivalent drug that doesn't have those side effects, then choose that one. For some children who are with epilepsy who are going to school, then some of the medications have an effect on their cognitive capacity and their ability to learn. And so in some circumstances, you choose a drug that didn't have those effects as much. And then lastly, it's often just trial and error. You try a drug and you try it for a period of time, usually a month or two, and you see if it works. And if it works, you keep going. And if it's not working, you adjust the dose up a bit, or you try a second drug. When I said that you should choose it based on whether it's focal or generalized, most children, many children, have more than one seizure type. So in that case, you need to choose a drug that overlaps between the two, between focal and generalized seizures. The drugs that work particularly well in focal seizures, carbamazepine is the drug, also called Tegretol. That drug works particularly well in just focal seizures. And so if a child's got temporal lobe epilepsy and they've got just having a focal seizure, then carbamazepine is probably the best drug. But other drugs that are commonly available, phenytoin and phenobarbital, they work quite well also in focal seizures, and they work okay if you've got generalized seizures as well. For generalized seizures, the best drug is sodium valproate. That is the best drug, but it's the most effective in generalized epilepsy, but it's not always available. And if it's not available, then phenobarbital is the next best drug for generalized seizures. Also, another drug which you might not have heard about called Levotoracetam, sometimes called Keppra, that's a very good drug for generalized seizures particularly, but also for focal seizures, so for children, and it has a very low side effect profile. So I think that's quite a good drug that hopefully will be available a bit more soon. Both sodium valproate's on the WHO Essential Medicines for Children list, and levotoracetam is soon to be on the WHO Essential Medicines for Children list. So hopefully those drugs will become a bit more available because they are slightly more effective in some types of epilepsy, and they have a lower side effect profile than some of the other medications. I wanted to say something about the mechanisms of action of anti-epileptic drugs, we don't need to be experts in how they act at a cellular level within the brain, but it's useful to know that there are different drugs have different mechanisms of action. We've already talked about the types of seizures most of these drugs treat, and I want to say something about the effect on liver enzymes, because many anti-epileptic drugs have effects on liver enzymes that we need to take into account when we're thinking about the use of other medications in children who have comorbidities, especially anti-TB medications and anti-HIV medications, so antiretroviral therapy. So I'd say a little bit about the effects of the epilepsy medications on liver enzymes, and yeah. Now, I never remember all of these things, but just to know that the anti-epileptic drugs have a number of different mechanisms of action. And the one reason to remember this, or to actually understand this, is that when you've got a child who's on one anti-epileptic drug and they may not be improving, and you've pushed the dose of that drug to a sufficient level, then when you're thinking about a different drug to use, a second drug to use, if you're thinking about the use of a second drug, it is important to choose a second drug that has a different mechanism of action. Okay, so there's no point really being a child being on phenytoin and carbamazepine because they're both sodium channel blockers. And so if you have a child who's not doing well on phenytoin, then there's no point adding carbamazepine because it won't add anything more to what the phenytoin is doing. So you choose another drug that has a different mechanism of action. Now, for some of these anti-epileptic medications, the mechanism of action is not exactly known, but there's broadly speaking, they can be sodium channel blockers, they can be calcium channel blockers, they can be GABA enhancing. GABA is gamma aminobutyric acid, which is a stabilizing neurotransmitter. It calms the brain down. And so there are some drugs, the commonly used drugs, phenobarbital, benzodiazepines, and sodium valproate, they enhance the production of GABA, this neurotransmitter, within the brain, and they tend to calm the brain, right? Then there's glutamate inhibitors. So these are relatively new drugs. So topiramate and felbamate, I've never used that, but those drugs tend to be fairly new. And then there's other ones that have unknown mechanisms of action, like levotoracetam, which I mentioned before, a good drug also called Keppra. That's a useful drug. And then an old drug, which is acetazolamide. And many people won't recognize that acetazolamide, or what's called Diamox, has an anti-epileptic function. But for children, for example, there is a specific indication. I think this can be quite useful, and that is for children who've got TB meningitis, who have obstructive hydrocephalus of a mild or moderate degree, and they have seizures. And for those children, this acetazolamide or Diamox can be useful, but that's probably a fairly narrow indication. I've used it in such children, or a child with Haemophilus meningitis who had hydrocephalus and seizures recently with quite good effect. But that's a narrow indication. Just try to remember that some of these drugs have different mechanisms of action, and when you've reached the limits of the dose of one drug, and you want to add a second one because it's still not controlling the seizures properly, then choose one that's got a different mechanism of action. I'll just talk a bit about the commonly used drugs, and I'll go over the same information a bit more. As I said, phenobarbital is a GABA enhancing drug. GABA is this gamma aminobutyric acid, which is a stabilizing, calming neurotransmitter. It reduces the neural firing within the brain. And phenobarbital is primarily for generalized seizures. It has some side effects, as we know. It causes sedation. For children that are on phenobarbital chronically, it can lead to difficulty in concentration and in mood changes and depression. I think this is one of the reasons why many newer forms of anti-epileptic medication have been developed, because phenobarbital, which is a highly effective medication for epilepsy, highly effective, but for school-age children or children trying to develop and learn, it can be a bit blunting on their ability to learn. If you're on phenobarbital for a long period of time, just the same as if you're on some other anti-epileptic medications, you can have reduced bone density. And so children who have epilepsy, we need to think about their bone density, especially if they've got comorbidities as well. But consider that, and consider how we can improve that. I'll mention that soon. Phenobarbital is also useful for focal seizures, but carbamazepine is better. So if you've got the choice, then use carbamazepine. Phenobarbital is a potent inducer of cytochrome P450 microenzymes. And remember, I said that not all, but many of the anti-epileptic drugs have effects on liver enzymes, and they can either induce the microsomal enzymes, so they're enzymes within the liver that metabolize other drugs and other substances. And so phenobarbital induces, that means it makes more enzymes. So if you're on phenobarbital, then there'll be more cytochrome P450 enzymes within the liver. And that means that other drugs that are metabolized by the cytochrome P450 enzyme system will be metabolized more quickly. And that's why we need to remember that's why we need to remember the interactions between these drugs when we are prescribing other medications that are metabolized by the liver, so rifampicin and other medications particularly. Phenytoin is another good anti-epileptic drug, but that's a sodium channel inhibitor. Remember, phenobarbital is a GABA enhancer. Phenytoin is a sodium channel inhibitor. And that's good for focal or generalized seizures, but there are other drugs that are better for both. So carbamazepine is better for focal seizures. Sodium valproate is better for generalized seizures. There are a number of side effects with phenytoin, and these are some of the things that I find that young teenagers don't like. They don't like the effect on their gums and their lips. So it causes quite substantial gum hypertrophy. A proportion of children will get a rash with phenytoin. It's still a very good drug, but it does have these side effects. It also, probably even as much or more than phenobarbital, reduces bone density. So if you've got children that are on phenobarbital or phenytoin, and especially if they're on both, then it can lead to impaired bone density and even pathological fractures. If you take too much phenytoin, then phenytoin is neurotoxic as well. So that's why the doses need to be carefully considered, and you don't go above a certain level. So in overdose, it can cause neurological side effects. Like phenytoin, it's a potent inducer of cytochrome P450 enzymes. So if a patient is on phenytoin and they're also starting some other medications that are metabolized by the liver, you need to be careful about the doses, the levels of those other drugs. Carbamazepine, as I said, is a good drug, also called Tegretol. It's a good drug for focal seizures. It's also a sodium channel inhibitor, just like phenytoin. And it has some side effects, but they're not usually severe. Sometimes nausea, vomiting, gastrointestinal side effects. Sometimes carbamazepine can induce rashes. Like it's a small proportion of children will get a rash to carbamazepine. Sometimes it can go on to develop something more severe, like Stevens-Johnson syndrome, and that is a more florid erythematous rash, erythema multiforme. That's rare though. That's very rare. Less than 1% of all children that you start on carbamazepine will develop that. And most of the anti-epileptic drugs sometimes can cause bone marrow suppression, so leukopenia or sometimes aplastic anemia. Carbamazepine is also an inducer of cytochrome P450 enzyme. So again, if you're starting a patient on a medication that is metabolized by the liver, then sometimes the dose of that medication has to be higher to achieve a therapeutic aim, because the liver will be metabolizing that second drug more actively. And then lastly, I wanted to just briefly mention sodium valproate. It's also called valproic acid or Epilim. So it's all the same drug. It's also a GABA enhancer. So remember, GABA, gamma aminobutyric acid, is a calming neurotransmitter within the brain. It reduces the firing of neuronal networks. It's very good for generalized epilepsy, and it's probably the drug of first choice. Occasionally, it has some toxicity. So occasionally, about 1% of children get some sort of liver dysfunction. So their transaminases may go high. Usually, it's not very severe, and less than 1%, so 0.1%, can get pancreatitis. And so you need to, if a child's on valproic acid, it's ideal if you can measure their liver function tests once a year or every 6 months, and if you tell them that if they get abdominal pain or any central abdominal pain or upper quadrant pain, right upper quadrant pain, then to represent as soon as possible. Sodium valproate, Epilim, valproic acid is teratogenic. So you don't treat adolescent girls with sodium valproate because it can cause birth defects. And sodium valproate is unlike phenytoin, phenobarbital, and carbamazepine. Sodium valproate is an inhibitor of enzymes, so that will reduce the cytochrome P450 enzyme. So that means if you give another drug that is metabolized by the liver, then and you give it at the normal doses, then sometimes the doses of that drug, the second drug, will be high, and so that can lead to toxicity of the second drug. Right, and that's the case for children on AZT who are also on sodium valproate. Right, they need children who are on zidovudine need a dose reduction of their zidovudine if they're also on sodium valproate because of the inhibition of the liver enzymes. Some of the side effects. This is a child who had gum hypertrophy from phenytoin, but it also can occur with other anti-epileptic drugs, but it's something that a lot of teenagers don't like. So children going to school often are troubled by the cognitive effects of some of the anti-epileptic medication, and children who are a bit older are often troubled by the gum hypertrophy. Mouth care is very important for children with epilepsy. It's really important that their parents are taught how to clean their child's teeth and how to look after their kids' teeth. Drug rashes are not really common, but they do occur in up to 10% of all children on carbamazepine. You just need to be able to recognise it. They're usually erythematous rashes that occur on the limbs. And if you recognise a rash like this, then just reconsider whether the child think about another drug to use. So just to summarise this concept of cytochrome P450 enzymes and drug interactions, remember I said 3 of them are inducers of P450 enzymes, so carbamazepine, phenytoin, and phenobarbital. They induce the enzymes. So if you're on rifampicin, is also an inducer, and if you're on some other medications like zidovudine, then you may need to increase the dose because there's more enzymes available to metabolize the second drug. All right. Rifampicin is an inducer of cytochrome P450 enzymes. The inhibitors, sodium valproate and isoniazid. And if you're on another drug that's metabolized by the liver, then the level will typically go up because you're inhibiting the enzymes that metabolize the liver. It depends whether the drug's metabolized to an active metabolite, so it can be a bit confusing. But just remember, if a child's on any of these anti-epileptic medications and you're thinking about starting another drug, then you need to look up the drug interactions. I just wanted to say something about the effectiveness of treatment, and it's said that 70% of children who have epilepsy can go on to being free of seizures. Now, if we looked at all the children with epilepsy in our clinics, that might not be the case. You might say that, well, there's more children have ongoing seizures, and that might be so, but perhaps we're seeing a biased sample of the population. And I think it is true that if you look at children overall, then about 70% of all children who have epilepsy can achieve can be seizure free, usually with one drug. And what's important is that most children can be seizure free with just one medication. Now, if in the 30% that are resistant to one drug, then the way you consider how to treat them, first of all, you should look up the dose of that drug and see what the maximum dose that you can use is. And if there's no side effects, then I think pushing that drug to the maximum dose is the right way. If there's no side effects, and especially if it's had a small effect to begin with. If the child's still resistant, that is that one drug to its maximum dose or its optimal dose didn't stop the seizures, then you can start a second drug. But again, as I said before, you should choose a drug that has a different mechanism of action and ideally a different side effect profile to the first drug. And then if the second drug works, then you should slowly withdraw the first drug. You don't need to just well, one, you shouldn't just stop it abruptly. You should withdraw it over the course of about a month, typically. And then you've got one, then the child's again on monotherapy, which is, again, most children respond to monotherapy and can have their seizures controlled with one drug. The risk of mortality is a bit increased in children with epilepsy, as in both high and low income countries. But it's, the World Health Organization says it's much higher in some populations, in children in rural areas, particularly in low income countries. But it's important to know that some types of epilepsy don't have an increased risk of mortality. So for most parents, hopefully most parents who have children with epilepsy, their child won't have an increased risk of mortality. Remember I said benign Rolandic epilepsy, you can be quite reassuring about that to parents, that there's no major risk to their child, and then they'll treat them normally. Still, all children, some of the increased risk of mortality comes from falls or drownings or burns. They're quite common in children who have epilepsy. So we need to be telling parents of children who've got epilepsy how to protect their child from environmental risks, about not letting them climb trees or ride bikes without supervision, or going into water, whether it's a bath or a river or a swimming pool. They shouldn't go into that without an adult being within arm's reach of them, etc. So these things are very important to explain to parents who have children with epilepsy. We see quite a number of children each year who drown from epilepsy, and sometimes they even drown in the bathtub because the parents left them alone and they have a seizure. These are preventable causes of death in children with epilepsy. There is a form of sudden death in children with epilepsy, and I don't think it's very well understood, but it's called SUDEP, or sudden unexpected death in epilepsy. And some children who have poorly controlled seizures are at some increased risk of this thing called SUDEP, or sudden unexpected death in epilepsy. It's not really known why. There might be some connection, I think, between the brain and the heart in terms of a child has a seizure, they might aspirate. There's a variety of different reasons why some children are at increased risk of death in epilepsy. But most, as I said, most children with epilepsy are not at that increased risk. Children who have well-controlled seizures, if the child's seizures are well controlled, then that markedly reduces the risk. So most of these cases of sudden unexpected death in epilepsy occur in children who are not in remission. We should think about that when we are treating children, whether they are or aren't in remission, and what we need to do to get that child into remission in terms of the anti-epileptic medications. I will just mention briefly a study that's worth reading by Kasparia-Mond. This was Kasparia-Mond's master's thesis, and she looked at the outcomes for children with epilepsy in Papua New Guinea, and she followed 47 children with epilepsy for 18 months. It's a very, very good study, and it tells us a lot about how to look after children with a chronic illness. And the chronic illness, of course, in this case is epilepsy. But she studied these children over, as I said, 18 months, and about half of them had developmental disability as well. Sadly, only a quarter of them who were eligible to attend school went to school. And the things I mentioned before, injuries and burns, were quite common among these children. Most of them were on phenobarbital monotherapy, and she found that when she increased the doses to appropriate doses, or changed the medication to another drug along the lines that I've mentioned before, that many had improved seizure control and better treatment, and some of them got back to school. So this is a good study of how to manage children, I think, with epilepsy, and I commend it to you. All children with epilepsy, this is my last slide, and this is like a summary in a way, in that all children with epilepsy need to because their seizures are they're different, they're unique. Every child's seizures are unique. Then every child with epilepsy needs to have a management plan, just like every child with asthma needs a management plan. And that I find it useful to use something like this, some sort of form that has this information on it, and I give that to the parents. And then whenever they present to another hospital or they present to another doctor, then at least that doctor has can have an understanding of the child's epilepsy. And so in the individualized management plans, I think it's useful to have the type of epilepsy, the seizure frequency, roughly how often do they have seizures, if they've got other comorbidities, the anti-epileptic treatment they're on, and if they've tried others in the past, I usually mention that. The contact people, so who to contact if the child has a seizure, and also include in it for the parents' sake, what parents and other health workers should do when the child has a seizure. So how to safely put the child in a position, what extra drugs that they can give or that they should use at home, when the parents should take their child to the hospital or the health clinic, and when to have a medication review, which really should be at least every 6 months, but usually sometimes more common than that, is more often than that when you're trying to trying to stabilize a child. So the main thing is to have an individualized management plan written down in the child's health record book, I think, is best, that has all this information on it. Okay. And then the last thing is, I think it's important to be, in children who have epilepsy, it's important that we are clear about what the goals of treatment are. And I think it's good to ask families and ask the children themselves as they get older, what do you want to achieve this year in terms of your treatment? And sometimes it will be about not having seizures. Of course, that would be good. But sometimes it can be just about going back to school or what they want to do at school. And so having goals of treatment that are not just about medical things, I think is useful. You need to educate parents about physical safety, about, as I said, water, fire, bicycles and trees. They're the 4 most dangerous things, I think, for children who have epilepsy. It's good to have a goal of being free from complications of their anti-epileptic medications. So you can do that by having good oral hygiene, like brushing your teeth. You can use chlorhexidine mouthwash to clean the mouth. Vitamin D supplements, I think, can be useful in such children because, as I said, they can develop brittle bones, and vitamin D deficiency is quite common in children with epilepsy. And it's probably one of the reasons why these children are a bit more at risk of getting pneumonia and other infections as well. Some of the anti-epileptic medications are folic acid inhibitors. And so it's useful for some children to be on folic acid supplements as well. And I think it's important to really explain to children with epilepsy and their families that if the child's looked after properly and gets the right medications and goes into remission, then they can go to school and they can do things that are normal and have a good life. There are many people who've got epilepsy who have high educational attainment and get good jobs and have families and do normal things. So I think it's important we educate families about epilepsy and about the good outcomes that can occur, and that empowers them to look after their children. I think I was going to say something about stigma, and that's just really part of this, because there are certainly in some, Caspar Amond found that stigma was quite common among the families that she looked at. Many of these children had been the subject of stigma and discrimination, and it's important that we get the right messages out, that 70% of children can be seizure-free with treatment and live happy and productive lives, that it's not contagious, it doesn't spread from one person to another. These children or these young people are not mad, and they're not possessed by evil spirits, and they don't need to be hidden away, but they can go to school and they can do other things, and yeah, that's important. Okay. All right, well, that's all I want to say. It's just a quick run through of epilepsy and all the different things we need to think about in terms of medications and how to adjust treatment, etc. So I'm going to stop talking now, and if anyone's got any questions, please feel free to ask.
Hello, Prof.
Yeah, Glenson, hello.
Hello, Glenson. Thank you very much for the wonderful presentation. I have two questions I would like to ask. First one is, so if we put patient on anti-epileptic drugs and then they become asymptomatic, how long do we take until we start thinking about stopping the anti-epileptic drug?
Yeah, thanks.
That's the first question.
Yeah. Can I answer that one first? Oh, okay.
Okay.
Yeah, because that's a very good question, and I think that how long you would keep if they go into remission, let's say, then you need to think about how hard it was to get the child into remission. So if it was very hard to get the child into remission, if they had multiple seizures and even seizures during your escalation of the medication, then I'm quite reluctant to stop the medication if it's working well for at least the first 12 months. So I probably wouldn't stop within 12 months or even 2 years if they've been hard to get into remission. If they've got an underlying brain problem, a brain injury, some sort of comorbidity, some neurodevelopmental problems, or if they've had epilepsy as a secondary effect of meningitis or some other brain injury, then again, I'm quite reluctant to stop the medications or reduce the medications for at least a year or two. So it does depend on how quickly a child gets into remission and what their comorbidities are. But if they were quite easy to get into remission and they're seizure free for 6 months, then I think it's reasonable to reduce the dose a bit. But I wouldn't go for any less than 6 months. And for some children, I'd wait for a year or two before I reduce the dose. And what you find actually is some children sort of grow out of their medication. So of course you need to adjust the dose up as the child grows. But if they're in remission, I tend not to increase the dose. So over the next year or two, usually the child will have grown. So the dose that the child's on is a bit less than what it was, and that's effectively a reduction in the dose. Does that make sense? All
right, thank you very much.
Yeah. So somewhere between 6 months and a year or two, I think, is the right answer. Yeah. And your second question?
And my second question is about, so we have lots of babies with severe beta asphyxia, and one thing that we've seen is almost all of them would develop seizures after. And we're just wondering, probably it's not encouraged, but just wonder what do you think about them? Should we give prophylactic anti-convulsion drugs to them? I mean, anticipating that they probably get to have fitting soon. Should we give them?
Yeah, it's a good question. I mean, it relates as much to the management of severe birth asphyxia, doesn't it, as epilepsy? And I don't think I think it's an okay thing to give phenobarbital to children who've got severe birth asphyxia. Yes, I think that's all right to do. I don't know that that's going to prevent them getting epilepsy later on. But if you've got a child who's got severe birth asphyxia, as long as they've got adequate ventilation and their oxygenation is okay, if they have severe birth asphyxia, then it's okay to give them a loading dose of phenobarbital. But I certainly think you should also be careful about a few weeks ago, we talked about meningitis and encephalitis and the treatment of acute seizures. And if you remember, the use of more than one drug meant that a child was at greater risk of having respiratory depression and dying. That was for cerebral malaria and for meningitis, but it also applies to birth asphyxia, isn't it? So I'd be very worried about children who have birth asphyxia who are on phenobarbital and they get midazolam or diazepam and they get Praldehyde as well. I think that's a recipe for disaster. It's because they may get apnea or maybe more prone to apnea. So I think it's all right to use a dose of phenobarbital in those children, but as I say, I don't think it necessarily stopped them getting epilepsy later on. But one drug is okay.
Thank you very much.
Okay.
Good afternoon, Prof, and thank you very much for today's talk. Just a comment on febrile fits. We have some children that have more than 2 or more episodes per month. We do start them on some anticonvulsants. Just what are your thoughts on that? Thanks.
Yeah, thanks, Gwenda. Yeah, if they're otherwise normal children and they neurodevelopmentally normal, and each time the seizure is related to a fever and they don't have any other comorbidities, as you know, generally anticonvulsant medications are not only not necessary, they're actually not very effective. And there've been studies done a long time ago, of course, looking at the use of phenobarbital in febrile convulsions and looking at phenytoin and other medications, and they're not very effective. There are some things that can be a bit more effective. So sometimes if parents are having very frequent seizures, then sometimes for some parents giving some rectal diazepam can be helpful. There are some other studies done giving sodium valproate for children with very frequent and complicated febrile convulsions, and that has been shown to be effective. So while most of the medications that we use for epilepsy, phenobarbital, phenytoin, carbamazepine, probably aren't effective for febrile convulsions, sodium valproate probably is effective, but I would only use it in children that are having very frequent seizures that put them in hospital regularly. So that, yeah. What medication are you using, Gwenda?
It's mainly phenobarbital. Yeah.
Yeah.
Thank you.
Okay. Yeah. It's everything is a balance with the management of epilepsy, a balance between, you know, the effectiveness of the medication, whether it's effective at all, and then the side effect profile of the medication. And I don't know that, I'm pretty sure that the studies that were done many years ago showed that phenobarbital wasn't effective in febrile convulsions, actually. Others might know.
Thanks, Prof.
Yeah. Okay, well, if there's no other questions, then thanks for your time today, and I'll just